Predictors of difficult airway management and airway assessment. Introduction. A difficult airway can be defined as the clinical situation in which a conventionally trained anesthesiologist experiences difficulty with face mask ventilation of the upper airway, difficulty with tracheal intubation, or both. A more complete definition would include airway instrumentation, direct tracheal access, and consideration of the airway at extubation. The fourth National Audit Project demonstrated that poor outcome may be contributed by failure to assess for and identify potential difficulty, and application of poor judgment in management planning, identify risk factors for rapid hypoxemia, such as pregnancy, obesity, pediatric population, and existing hypoxemia. Before anesthesia, the anesthesiologist should be able to answer a few key questions. Will I be able to mask ventilate? Will I be able to perform laryngoscopy, directly or indirectly? Will I be able to intubate this patient? Is there a significant aspiration risk? If I predict difficulty, should I secure the airway awake? Can I access the cricothyroid membrane if needed? How will the airway behave at extubation? And where should I manage the patient's airway? Predictors of difficult airway management. History. Assess for history of previous airway difficulty, ease of mask ventilation, ease of laryngoscopy, what airway devices that had success or failure, anesthesia-associated dental damage or severe sore throat, and airway alert form. Seek history of acquired conditions such as pregnancy, obesity, diabetes, rheumatoid arthritis, ankylosing spondylitis, acromegaly, Still's disease, OSA, tumors, respiratory infection, conditions that increase aspiration risk, thermal or chemical injuries, etc. History of syndromes such as Down syndrome, Klippel-Feil, craniofacial, Goldenhar, Pierre-Robin, Treacher-Collins, etc. Iatrogenic conditions such as face or neck surgery, cervical spine fusion, oral or pharyngeal radiotherapy, laryngeal, tracheal, or TMJ surgery, etc. New or significant worsened pathology. A new clinical picture may require a different airway approach. Assess information on respiratory problems such as stridor, voice change, secretions, and for pediatric group, snoring, noisy breathing, change of voice, recurrent croup or sleep apnea. Assess for dysphagia, ability to lie flat, onset of swelling, pain, trismus if present, and most comfortable position at rest producing the least dyspnea, as this is the rescue position to revert to when the patient desaturates during airway management. Difficult mask ventilation may occur in the very young. Difficult intubation is associated with weight less than 10 kg, micrognathia, and more than 2 direct laryngoscopy attempts. Congenital disorders associated with difficult airway. Micrognathia leads to difficult intubation, such as in Pierre-Robin's, Treacher-Collins, and Goldenhar syndrome. Mid-phase hypoplasia leads to difficult backmask ventilation, such as Apert syndrome, Crozen, Pfeiffer syndrome, and Sater-Kotzen syndrome. Macroglossia leads to difficult backmask ventilation and difficult intubation, such as in Hurler's or Hunter syndrome, Beckwith-Wiedemann syndrome, and Down syndrome. Acquired disorders associated with difficult airway in children includes chronic obstruction, such as in tonsillar hypertrophy, glottic web, hemangioma or subglottic stenosis, acute obstruction, such as due to infection, foreign body aspiration and trauma, beware of laryngospasm, poor mouth opening or mobility of jaw and neck, such as in TMJ disease, spinal fusion, measles, stomatitis, and Burns contractures. Malampati score does not accurately predict a poor view of glottis during laryngoscopy in pediatric patients. Standard values of thyromental and horizontal mandibular lengths do not exist for the pediatric population. Physical examination. Examine the face and head. Facial hair may hide adverse anatomical predictors. Assess for syndromic facies, swellings and deformities, restrictive scars, and certain hairstyles that may cause difficult intubation. Assess the nose. Assess the patency of nasal passages. Identify septal deviation, polyps, or clotting abnormalities. Assess the mouth. Reduced mouth opening and temporomandibular advancement may be caused by dental abscess, quinsy, TMJ surgery, or radiotherapy. Assess for masses and swellings. Anatomical impediments such as small mouth, receding chin, beard, high arch palate and large tongue. Assess for dentition, anterior gaps, poor dentition, sharp, loose, protruding inward or outward teeth, dentures, single incisors or dental wires. Assess for intraoral bleeding or secretions, which may hinder glottic visualization. Assess the neck for bull neck, orthopedic equipment such as neck collar, masses such as goiter, tumor, hematoma or abscesses, cervical spine movement. Palpate the submandibular space. Non-compliant tissues may lead to difficult laryngoscopy and mask ventilation. Asking the patient to protrude their tongue may demonstrate limited mobility. Identify the cricothyroid membrane and restrictive scars. Assess the chest for predictors of difficult airway such as obesity, large breast or barrel chest. Perform predictive tests for difficult laryngoscopy, which shall be discussed later. Imaging. Chest radiographs may demonstrate distal obstruction, airway collapse, gas trapping, foreign bodies, soft tissue swelling and tracheal compression or deviation. Cervical spine X-rays may assess for occipito-atlantoaxial disease, reduced space between C1 spinous process and occiput, loss of cervical disc space, which predicts difficult intubation, and cervical stability in flexion or extension dynamic cervical spine studies. Ultrasound is useful to identify large midline vasculature to assess suitability for tracheostomy, identification of cricothyroid membrane, and predicting difficult intubation by various parameters such as tongue thickness, pretracheal fat at vocal cord level, and hyoid bone with sublingual ultrasound. Joint discussion with the surgeon or radiologist is useful with regard to causes of pathology, level and severity of any stenosis, and subglottic extension. CT scan may help assess facial fractures. Mandible fractures may increase the likelihood of difficult mask ventilation and laryngoscopy. Zygomatico-maxillary fractures should be assessed for fracture impingement on the coronoid process, as limitation of mouth opening leads to difficult airway. MRI is useful for soft tissue assessment, but the ability of many patients to lie flat for prolonged periods can be limiting. Virtual 3D endoscopy may be useful in assessing airway pathology, but these are unlikely to replace conventional endoscopic examination. Nasoendoscopy may be useful to assess upper airway anatomy and abnormalities, such as swelling, anatomical distortion, vocal cord palsies, tumors, and periglottic lesions. It helps planning laryngoscopy, intubation, awake tracheal intubation, and tracheal access. Normal nasoendoscopy does not guarantee straightforward airway management, as the induction of anesthesia leads to reduced pharyngeal tone, and this will affect airway patency. Predictors of difficult mask ventilation. Mask ventilation is difficult in 1 to 3% of cases and is impossible in 1 in 600 cases. Impossible mask ventilation may be defined as inability to achieve gas exchange despite the use of adjuncts, multiple providers, and neuromuscular block. A mnemonic to help remember predictors of difficult mask ventilation is obese fat man's, O for obesity, B for bearded, E for elderly, more than 60 years, S for snoring, E for edentulous, FA for facial abnormalities, T for thyromental distance less than 6 cm, M for male sex, MA for Malampati class 3 and 4, N for neck radiotherapy and neck circumference more than 40 cm, and S for previous difficult tracheal intubation. A diff mask score of 5 or more predicts difficult mask ventilation. This scoring uses 10 predictors of difficult mask ventilation and range of possible accumulated score 0 to 18. Predictors includes age, sex, BMI, previous difficult tracheal intubation, thyromental distance, Malampati score, presence of full beard, snoring, OSA, and neck radiation changes. Additional information: causes of difficult face mask ventilation includes equipment-related factors such as failure of gas delivery, size of airway adjuncts and size or shape of face mask unsuitable, disruptors of face mask seal such as edentulism, facial deformities, facial hair and foreign objects, upper airway obstruction such as edema, external compression, laryngospasm, OSA, posterior displacement of tongue or epiglottis, and tumor, lower airway obstruction such as airway mucus plugging, aspiration, bronchospasm, external compression such as mediastinal mass, foreign body and tumors, reduced respiratory compliance, such as abdominal compartment syndrome, chest wall deformity, gastric distension, obesity, pregnancy, restrictive lung disease and tension pneumothorax, technique-related factors, such as cricoid pressure, closing the airway, inexperienced or unskilled operator, and pharmacological causes such as inadequate depth of anesthesia, absence of neuromuscular blockade, and use of high-dose opioids. Methods to improve difficult face mask ventilation. For poor face mask seal, optimize the operator's position, optimize the patient's position, head tilt, chin lift, jaw thrust, and head rotation. Ensure the face is lifted into the mask rather than face mask pushed onto the face. Change to a two-handed or four-handed technique. Change of equipment, such as different size or shape of face mask. Remove any apparatus causing leak, such as nasogastric tube. For patients with facial hair, consider shaving, applying plastic film or saline soap gauze to the beard, or applying lubricant to mat the beard. For patients who are edentulous, consider leaving the dentures in place, use of excessive buccal tissue to assist with seal formation, or consider packing the buccal cavities with gauze. Challenges other than poor face mask seal: increased depth of anesthesia, apply CPAP, use nasal or oral airways, use suction if airway is soiled, give neuromuscular blocker, and treat underlying cause such as bronchospasm, foreign body, laryngospasm, or pneumothorax. Consider change of personnel. Consider alternative means of oxygenation such as SGA or intubation. Grading scales to classify the degree of difficult face mask ventilation includes the Concord grading scale, Hahn grading scale, and Water scale. For Concord grading scale, Grade A, EtCO2 plateau present. Grade B, there is no EtCO2 plateau. EtCO2 is 10 or more mmHg. Grade C, no plateau. EtCO2 is less than 10 mmHg. And Grade D, no EtCO2. The Hahn grading scale: Grade 0, ventilation by mask not attempted. Grade 1, ventilated by mask. Grade 2, ventilated by mask with oral airway or other adjuvant. Grade 3, difficult mask ventilation. Grade 4, unable to mask ventilate. For the Water scale, it uses a numerical point value to a maximum of 15 to quantify the difficulty encountered in achieving tidal volume of 5 mL per kg or more, based on factors that includes use of airway adjunct, peak inspiratory pressure generated, tidal volume generated, and number of operators. Predictors of difficult direct laryngoscopy. Direct laryngoscopy needs a line of sight from the upper teeth to the glottis and alignment of the oropharyngeal axis via head extension, pharyngeal-laryngeal axis via neck flexion to the laryngeal tracheal axis. It entails mouth opening, extension of upper cervical spine, and displacement of mandibular arch tissues. Predictive tests check one or more of these capabilities, but direct laryngeal view grade correlates modestly with difficult intubation. Most failures occur with grade 2 or 3. Functional grades have been proposed. The Cormack and Lehan's classification of laryngeal view grade 1 to 4 is included here. The Cook's modified classification of laryngeal view for grade 1 and grade 2A predicts easy intubation, glottis is visible, and intubation requires no adjuncts. Grade 2B and grade 3A are restricted views. Posterior laryngeal structures are visible, or epiglottis is liftable. Intubation may require a bougie. Grade 3B and grade 4 are difficult views. Epiglottis is not liftable or visible. The patient requires advanced technique to intubate. Predictive tests for difficult direct laryngoscopy. Problems. These tests provide frequent false positives and false negatives, and combining tests exacerbates these problems. Interincisor gap refers to the distance between the incisors or alveolar margins with the mouth open maximally. Less than 3 cm predicts difficulty. Less than 2.5 cm predicts difficult SGA insertion. Mandibular protrusion. Class A. Patient can protrude lower incisors anterior to the upper incisors. Class B. Patient can protrude lower incisors to but not beyond upper incisors. Class C. Patient cannot protrude lower incisors to the upper incisors. Class B and C are associated with difficulty. Upper lip bite test. The patient attempts to bite as far up their upper lip as they can. Class 1, lower incisors bite upper lip mucosa is invisible. Class 2, upper lip mucosa partially visible. Class 3, lower incisors fail to bite the upper lip. This is a strong predictor of difficult laryngoscopy. Mallampati test. The Mallampati classification is a scoring system used to predict difficulty in intubation. A score of 3 or 4 means that the patient is at high risk of being difficult intubation. It correctly predicts about 50% of difficult laryngoscopy and has a false positive rate of more than 95%. To assess Mallampati classification, a patient must be sitting upright, with the head neutral, mouth open, tongue protruded, and not phonating. The score of 1 to 4 is assigned based on which structures are visible. Class 1, tonsillar pillars, uvula and soft palate visible. Class 2, base of uvula and soft palate visible. Class 3, only soft palate is visible. And Class 4, only the hard palate is visible. Class 3 and 4 views are associated with difficult laryngoscopy. Mallampati test is prone to inter-observer variation. Extension of the upper cervical spine. This is assessed by flexing the head on the neck, immobilizing the lower cervical spine with one hand on the neck, then fully extending the head. Placing a pointer on the vertex allows estimation of the angle of movement. Placing one finger on the patient's chin and one finger on the occipital protuberance and extending the head maximally may be used to assess upper cervical spine extension. With normal cervical spine mobility, the finger on the chin is higher than one on the occiput. Level fingers indicate moderate limitation. If the finger on the chin remains lower than the one on the occiput, there is severe limitation. There is increased risk of difficult direct laryngoscopy. Thyromental distance or patile test refers to the distance between the tip of the thyroid cartilage to the tip of the mandible with the neck fully extended. Normally more than 7 cm, less than 6 cm predicts 75% of difficult laryngoscopies. Combined patile and Mallampati test increases the specificity to 97% and decreases the sensitivity to 81%. Sternomental distance or SAVA test refers to the distance between the sternal notch to the tip of the mandible with the neck fully extended and mouth closed. Less than 12.5 cm is associated with difficulty. Positive predictive value 82%. Thyromental height is a measure of vertical height from the anterior border of the thyroid cartilage and anterior border of the mentum. A cutoff of 50 mm allows optimal sensitivity and specificity for predicting difficult direct laryngoscopy. The Wilson score. A total score of 2 or more predicts 75% of difficult intubations, 12% false positives. Components includes weight, head and neck movement, jaw movement, receding mandible, and buck teeth. Menchoka score identifies critically ill patients at risk of difficult intubation. It consists of weighted variables, with M for Mallampati 3 or 4 given a score of 5, A for apnea or OSA given a score of 2, and the following given a score of 1, C for spine mobility, O for mouth opening less than 3 cm, C for coma, H for severe hypoxemia, and A for non-anesthetist intubator. Range of score 0 to 12. Score of more than 2 predicts difficult intubation. Predictors of difficult supraglottic device insertion. Introduction to generations of supraglottic airway devices. The first generation supraglottic airway devices are simple breathing tubes, usually with some form of mask or opening at the larynx. Examples include classic LMA, LMA unique, SureSeal LMA, Cobra PRA, and laryngeal tube airway. Second generation SGA includes the above features, plus provision for gastric drainage and improvement in protection against aspiration, integral bite block, and some may aid intubation. Second generation SGAs are more likely to succeed at first insertion. Higher laryngeal seal pressures compared to first generation SGAs, 26 to 30 cm H2O versus 15 to 20 cm H2O, may enable ventilation of patients with low chest compliance and use of PEEP. Ability for gastric drainage and high esophageal seal pressures may reduce aspiration risk. Examples include CombiTube, ProSeal LMAs, LMA Supreme, iGel, and Oragain. Third generation SGAs includes the above features and incorporates dynamic sealing mechanism such as PASCA, ELISA, and 3GLM. Difficult SGA placement is associated with narrow gate, intraoral or pharyngeal masses, obesity, poor dentition, severe anatomical abnormality, swelling of upper airway, and bleeding after repeated attempts at tracheal intubation. Saito et al. Developed a scoring system to predict difficult ventilation through a SGA. Perioperative variables and their scores includes male, score of 1, age more than 45 years old, score of 1, short thyromental distance less than 5.5 cm, score of 3, and limited neck movement, score of 2. A total score of 4 or more is associated with 6 to 7 times increased risk of difficult ventilation through an SGA. Additional information included here is a non-exhaustive list of subjective, indirect assessments and clinical tests of correct supraglottic airway device placement, which includes gastric insufflation test, soap bubble drain tube test, gauze thread drain tube test, suprasternal notch test or Brimacombe bounce, self-inflating bulb technique, the track light wand test, gastric tube test, and maximum minute volume ventilation or hyperventilation test, which is described in more detail in an article by Van Zundert et al. In 2021. Next is predictors of difficult video laryngoscopy. This includes narrow and rigid oral or laryngopharynx, such as due to tumor, trauma, cervical pathology, or radiotherapy, fixed neck flexion, and increased secretions. In an article by Aziz MF et al., they have identified predictors of difficult video laryngoscopy as being in supine stiffing position, limited mouth opening, present for otolaryngologic or cardiac surgery, intubation by attending anesthetist, and inadequate laryngeal view. In a study by Kim H.J. et al. In 2022, they have identified predictors of difficult video laryngoscopy as being male, obese, having short thyromental distance, limited mouth opening, and high upper lip bite test class. Predictors of difficult front of neck airway includes obesity, goiter and other anterior neck masses or vessels, infection, neck scarring, tracheal deviation, fixed neck flexion, previous neck radiotherapy, surgical collar or external fixator preventing access. Predictors of difficult awake tracheal intubation includes inadequate oxygenation, uncooperative patient, operator or assistant inexperience, suboptimal environment such as in the emergency department or ICU, airway blood or airway secretions, inadequate topical anesthesia, oversedation, inability to pass a nasal tube, ill-fitting adjuncts such as fiber optic bronchoscope conduits, very narrow airway, and larger tracheal tube. For additional information, kindly refer to the video Finals NS SAQ Awake Fiber Optic Intubation. These are my references. Thank you.